Welcome everyone to the SAB's March educational webinar, Diagnostic Bronchoscopy in the Immunocompromised Host, Can Less Be Enough in 2023. Before we get started, I want to remind everyone that you have joined in a listen-only mode. Please submit all your questions using your question feature on your control panel. We will address all the questions at the end of the lecture. Dr. Kashishin is on the SAB Education and Program Committee. He will be moderating tonight's session. Dr. Kashishin.
Good evening, everyone. I want to welcome you to today's webinar. It is my honor to present our guest speaker today, Dr. Oleg Epelbaum, who is also my mentor, and he was a Pulmonary and Critical Care Fellowship Program Director during my training. Dr. Epelbaum is a clinical associate professor at New York Medical College in Westchester Medical Center. He's currently is a program director of Pulmonary and Critical Care Fellowship Program in Westchester Medical Center. He's also serving as the president of New York State Thoracic Society. Dr. Epelbaum has a lifelong interest in medical education and teaching. He's a true advanced bronchoscopist and educator. Today, we're going to learn about diagnostic bronchoscopy in immunocompromised hosts in modern era. Dr. Epelbaum, thank you again for joining us tonight, and you have the floor.
Thank you very much, Savak, for that great introduction, and thank you to the SAB for the kind invitation. So in the next hour or so, we will, of course, address the topic that you see on your screen. It says diagnostic bronchoscopy in the immunocompromised host. When we talk about diagnostic bronchoscopy in the immunocompromised host, of course, the focal point of that is typically infection. And the situation will be no different today. And the framing of the question is really, can less be enough? Not the more familiar, can less be more? And so hopefully this is a motif that you will see play itself out repeatedly in the course of the presentation. So I'm coming to you, as Dr. Kashishin mentioned, from Valhalla, New York, just north of New York City. Beautiful Hudson Valley. Here on the left side of the screen, you see a picture of Westchester Medical Center. At the medical center, as I say, nobody has a normal immune system, and nobody has normal coagulation. So certainly this is a topic that is very relevant to what goes on here. And on the right-hand side is an image of New York Medical College, which is right next to the medical center here in Valhalla. So for disclosures, I have no relevant disclosures. I will discuss some commercial products during this talk, but I have no conflict of interest related to them. One other disclosure I would add is that I'm not interventional pulmonology trained, but rather I'm an old school bronchoscopist, I would say. And so, of course, you might argue that for somebody who doesn't earn his living with bronchoscopy, it's easy to argue or talk about less being enough when it comes to bronchoscopy. And if I do have an agenda in the course of this talk, you may notice that, and I think so be it. And so what will be the objectives? One will be to review the historical performance characteristics of flexible bronchoscopy in the immunocompromised. We'll also assess the incremental benefit of biopsy over BAL in studies of the immunocompromised host. I will provide you with an overview of modern molecular testing of BAL fluid for opportunistic infections, with a focus on my specific area of interest, which is fungal infections. And I will hopefully also convince you that when it comes to opportunistic infections, majority of what we're concerned about, the focal point, is really fungal infection. And if I do have an agenda, possibly it will be to argue for an ever-diminishing role of biopsy for opportunistic infections in the immunocompromised host in the era of modern BAL fluid testing. And certainly, you know, this has been the subject of some somewhat heated discussions within our institution between myself, perhaps, and our interventional pulmonology colleagues. And so we each may have our own unique take on the subject. So just to lay it, to sort of lay it out there, I just wanted to quickly establish right off the bat the categories of immunocompromised states that I will be considering when talking about immunocompromised hosts. One, of course, will be malignancy, frequently associated with neutropenia, and immune compromise can also come from certain medications for its treatment, aside from neutropenia, such as, for example, treatment with rituximab and impairment of B-cell function. This list, of course, includes hematopoietic stem cell transplant recipients, part of whose course is often neutropenia, sometimes prolonged neutropenia. There could be subsequent immunosuppression for graft versus host disease. Third category is solid organ transplant, of course, with its associated immunosuppression. Another category is HIV. Fifth category would be immunosuppressive medications such as steroids, non-steroidal immunosuppressives, and novel biologics. And a smaller category, less perhaps relevant to daily practice, would be certain inborn immune defects. And this list actually is very timely. It comes from a document published literally just days ago by some of my colleagues from the ATS in the White Journal, where they published a statement or a document related to pneumonia in the immunocompromised host. And so this list comes from there, and it's very timely for this talk. So I'll show you this photograph, I guess, to perhaps set the stage for the discussion that will follow. And on your left-hand side, you'll see a vehicle that I photographed driving just past my residence some time ago in the borough of Queens in New York. And the reason that I show this image on the left is that if you think about the car passing by my house in, let's say, 2022 or 2023, it's certainly a very functional vehicle. It does the job. It was manufactured in the 1950s, perhaps 1960s. And why didn't we just continue manufacturing these same cars? Industry did not stop with this very functional, very well-built, very nice-looking car. But over the years, there was progress made because it was felt that this is probably not the ideal vehicle, because a more ideal vehicle could be, for example, more fuel efficient, it could be safer, it could be easier on gas, etc. And so things that we find to be acceptable, to be a certain standard in a particular era, certainly are subject to evolution, and we as humans always feel that there's perhaps room for improvement, there's room to move forward, and what served us well in the past is not necessarily something that we would want to continue doing forever. And so perhaps the analog of this in more familiar thoracic medicine terms might be the image on the right, which shows you the big scar of a posterior lateral thoracotomy. Certainly a very legitimate surgery, a very serviceable surgery, a surgery that can accomplish many, many things. But there's certainly a reason why the field has evolved to include first, video-assisted thoracoscopic surgery, and now the standard perhaps being robotic surgery. And so this was part of the evolution of something that was once considered standard and is still a very legitimate option, perhaps, but no longer optimal, no longer sort of the present, but more so relegated to the past. And so this has happened in our field recently. There's, I think, a few illustrations of how yesterday's standard or yesterday's advance even can become today's history or today's past tense. So, for example, an illustration of this would be this trial published in the New England Journal in 2015, which was really revolutionary and suggested that bronchoscopy with brushings of the mainstem bronchi could really risk stratify patients with pulmonary nodules seen on CAT scan. And so this was really earth-shattering, because it turns out that a minimally invasive, essentially bronchoscopic procedure could revolutionize the way that we approach the diagnosis, or at least risk stratification of pulmonary nodules. And yet, fast forward less than certainly about 6 years later only, and now we're no longer happy with the need to perform a bronchoscopy and perform brushings of the mainstem bronchi for this genomic classifier. And now all the rage is that we simply brush or scrape the nose of a patient and get the same information. More than that, even now we're starting to get studies suggesting that we can perhaps obtain the same information without even touching the patient, but rather by just collecting a blood sample. And similarly, another example might be this review article published about 10 years ago now in the Blue Journal that I remember scrutinizing as a junior attending, which went over in detail about how to optimize the collection of EBIS GBNase FNA specimens and to maximize their yield for molecular genetic analysis when this was all the rage, how to convert small bronchoscopic samples into adequate material for molecular genetics. That having been said, now again, fast forward about 10 years, and all the buzz, all the rage is really about the fact that we can potentially just take a blood sample and obtain cell-free DNA and get the same information about molecular genetics without really necessarily introducing a bronchoscope into the patient. So I'm going to transition to this slide now and talk about what historically, or in more recent times, also has been published regarding the yield of fiber optic bronchoscopy, of flexible bronchoscopy rather, in the immunocompromised host. It'll be a little bit of a whirlwind tour, like a kaleidoscopic slide here, but I will try to cover the highlights of a few studies. These from some years ago now. I start with a classic one, co-authored by Atul Mehta, of course, name very familiar to the bronchoscopy community. This was a study of 104 various immunocompromised patients from the Cleveland Clinic. The majority of these were patients with heme malignancy, but interestingly, the main reason for immunosuppression was actually corticosteroid administration. This was a 2004 study, so the BAL that was performed on these patients just included the standard studies available at that time, as listed, I'm sure, in Dr. Mehta's now seminal textbook on bronchoscopy. And in overall terms, the BAL diagnosed 65% of bacterial infections in this population, 75% of viral infections. But notably, and this is an important number to keep in mind, and I highlighted here, 40% only of fungal infections. And as I mentioned, it's really the fungal infections that constitute the bulk of the opportunistic infections that we worry about in the immunocompromised host. The addition of biopsy to BAL increased the overall yield over BAL alone significantly. But what's noteworthy is that biopsy was exclusively diagnostic in only 2 cases of infection. And it's probably not coincidence that these 2 infections were, one, Candida, which was very rarely implicated conclusively in lung infection. And so, vast majority of the time, that's an airway colonizer. And so it's pretty much impossible, in my opinion, to make the diagnosis of Candida infection of the lung, invasive infection, unless it is seen on a biopsy specimen. And the same difficulty applies to CMV, of course, which can be an innocent bystander in the lung, and so can convincingly be diagnosed as pneumonitis, typically only in the presence of biopsy findings. And so in the table below, you see these 2 infections listed, as well as the other diagnoses that were exclusively made by biopsy in this study. And you can certainly see on this list the familiar entities that are next to impossible to diagnose with only BAL. Noteworthy as well is the 31% complication rate with biopsy in this study in experienced hands, with 13.6% complications when biopsy was not performed, and this difference was significant. In the same year, 2004, a European group published a study now of just limited to heme malignancy patients. And actually, interestingly, the title of this study pretty much sums up the study's findings. And verbatim, it says that pulmonary infiltrates in patients with hematologic malignancies, transbronchial lung biopsy increases the diagnostic yield with respect to neoplastic infiltrates and toxic pneumonitis. And so that's illustrated nicely here in one of the tables from the study. And so if you look at overall yield of BAL versus BAL plus biopsy, certainly there were more diagnoses made with the combination. But what you also see is that that difference is accounted for by two categories of diagnoses: neoplastic infiltration, what presumably refers to leukemic infiltrates, and also toxic pneumonitis, which presumably refers to mostly drug-induced pneumonitis. However, when you look at the infectious category, you see that actually on an absolute basis and on a percentage basis, BAL procedures yielded more infectious diagnoses than the combined procedures. The fourth historical study was published in 2005 from the Brigham in Boston. This was limited to bone marrow transplant recipients. And a couple of bottom line points here are that 82% of all biopsies yielded nonspecific histology, and less than 10% of the biopsy patients or biopsies that were performed added specific information to the BAL for those same patients. Now fast forward a little bit closer to contemporary times. This study from the University of Michigan from 2018 looked at all patients in the study had biopsies. These were stem cell transplant recipients. There were a total of 5 or 4% of cases in which the biopsy identified an infection. Two examples of those infections were nocardia and aspergillus. And the most common histology, 18% of the biopsies yielded the dreaded nonspecific interstitial pneumonitis. And biopsy was not significantly associated with increased odds of a therapeutic change, as you see there. And procedural complications were more common than with BAL alone, and that was a significant difference. I think the most contemporary study on this subject actually was published in 2021 out of the Mayo Clinic. This was again a population of a variety of immunocompromised hosts. And the way that patients for this study were identified is that they had to have undergone BAL with testing by what they call the immunocompromised host panel at the Mayo Clinic, which you see there in the top right-hand corner of your screen. So all patients had to have this panel as well as a biopsy performed. And if you quickly scan this panel, and as hopefully you'll appreciate as we go along in this talk, this is a rather comprehensive panel of relatively contemporary testing, but by no means an exhaustive panel. There are certainly important items missing from this panel, and this study was, the patients from the study came largely from maybe the decade of the 2010s or so. And the overarching result here was that biopsy added findings beyond this immunocompromised BAL panel in 63% of cases. In 28% of cases, it led to actual management change. What I'd like to get into a little bit in a little more detail are the two bar graphs below on the bottom. They may be somewhat hard to read, at least the text, but I'll try to quickly guide you through this to relay the main idea. So here on the left-hand side, bar graphs correspond to different findings that biopsy yielded in different categories of immunocompromised hosts. And so just to drive home the point, infection is represented by the burgundy color, and you see how little of that burgundy color is depicted on this graph. Here you see a small blip in solid organ transplant recipients, but really it's entirely practically missing from all other categories. What you see prominently displayed, however, are the green bars, and those correspond to organizing pneumonia. And you see that these bars are pretty long, particularly in malignancy patients, which is perhaps not surprising because there are many ways that malignancy patients could acquire organizing pneumonia. It could be a reaction to the malignancy itself, could be a reaction to chemotherapeutic treatment, could be a reaction to radiation therapy. And so you can see how the finding of organizing pneumonia on biopsy really dwarfs the finding of infectious organisms. And if you move over to the right-hand side, this graph depicts management changes that occurred as a result of bronchoscopy in this study, a result of biopsy specifically in this study. And here you can see the burgundy lines actually represent change in steroid administration, and you see that that was the primary management change that was induced by biopsy, whereas change in antibiotics is depicted in this lilac or violet color, and you see how relatively rarely did biopsy lead to a change in antibiotic administration, but much more often led to a change in steroid administration, probably correlating with the predominant finding of organizing pneumonia. A couple of points from this study also about opportunistic infections specifically. Only 6 out of 16 patients who had fungus isolated on BAL also had fungus detected in biopsy. So only 38% of BALs positive for fungus were also positive for fungus on biopsy. There was no case in which fungus was identified on biopsy but not on BAL. And there were no additional organisms that biopsy identified in any neutropenic patients over and above what was identified on BAL. So we're really here to talk primarily about opportunistic infections, and of course, fungi make up probably the bulk of that category. But I just wanted to remind you in passing not to forget about bacterial pneumonia in the immunocompromised host. So here's a nice illustration of a case at our institution of a 72-year-old male, a kidney transplant recipient, came with here this left upper lobe consolidation, had biopsy performed. Perhaps now you may have expected that biopsy was yielded nonspecific findings. However, BAL culture was positive for something called Ralstonia manida-lylitica. If you haven't heard of this organism before, neither have I. Perhaps it could be considered an opportunistic bacterial infection because it's not supposed to be found in humans with normal immune systems. But I just wanted to put this in there to remind you that not all opportunistic infections are non-bacterial. The bacteria are not to be entirely overlooked. And we all know the problems with bacterial isolation from BAL, where we've been historically limited to cultures, which of course are associated with inherent delays. There can be sensitivity or yield problems to begin with, and especially if antibiotics are being administered. So the present of bacterial diagnostics in BAL, or maybe soon to be even the past, are these so-called multiplex bacterial PCR platforms or pneumonia PCR platforms. There are 2 of them that are FDA cleared. I'm showing you here probably the more prevalent BioFire platform, and here you see a list of organisms that is capable of identifying with a very rapid turnaround time. You see that there are typical pathogens, bacterial pathogens, atypical ones, viruses. You also can identify antimicrobial resistance genes with this multiplex panel. Many institutions across the country already employ this technology. We're currently actually working on adopting this at our institution. There's also a second option, manufacturer being Univero. You can see here a similarly exhaustive panel of the most common bacterial offenders, as well as the most common antibiotic resistance genes. What does this technology translate into in practice? This is one example of one study looking at the BioFire platform. Very similar data are available for the Univero platform, and the numbers actually match up quite closely if you look. This is a study of 259 BAL specimens that were subjected to both standard of care, which is culture-based diagnostics, as well as the multiplex pneumonia panel. And you can see here that in 38 of these BALs, or 15%, bacterial techniques were negative, whereas the panel actually identified a pathogen. And in panel B here, you're now looking at all the bacterial pathogens identified in the study. And you can see that in half of the bacterial pathogens were picked up by both culture-based standard of care and the panel, but almost another half of pathogens were actually picked up only on the panel and were missed by culture-based diagnostics. But as I mentioned, we're really here to talk in more depth about flexible bronchoscopy for opportunistic infections, classical opportunistic infections. What are those? As I mentioned, they're primarily going to be fungal infections, and so the remainder of the talk will focus heavily on Aspergillus, Mucorales, and Pneumocystis. I would throw in this category also disseminated endemics in those states that have a high burden of them, particularly. As I mentioned, I showed you an obscure bacterial opportunistic pneumonia. There are some more typical opportunistic infections among bacteria. I think nocardia is a classic example. One could also include Legionella on that list because impaired cell-mediated immunity is in fact a risk factor, though of course patients with completely normal immune systems can get this, as they can also get nocardia to be complete. Opportunistic infections can be viral. Good examples would be CMV as well as HHV6 and HHV8. In my opinion, they can also be mycobacterial. Of course, normal hosts get MTB all the time. However, if you encounter a patient with disseminated MTB, those are often hosts with impaired immunity. So why would we be inclined to do a lung biopsy for opportunistic infection or suspected, let's say, fungal infection of the lung? One reason is that it is one of the precious few ways in which to establish what is considered to be proven invasive fungal infection of the lung. And when we say proven infection, fungal infection, we're really referring to the EORTC MSG consensus definition document that I'm excerpting here for you. This is really a group of experts that get together periodically and update definitions of invasive fungal infections and categorize them into proven, probable, and possible. And so, of course, proven is a situation in which there can be really no doubt that this is a true infection as opposed to a case of colonization or a case of suspected infection. And certainly we sometimes may be inclined to prove beyond a reasonable doubt that this is what we're dealing with. And really in the lung, biopsy is one of the few ways, as I said, to fulfill the criterion for proven invasive fungal infection. And there are other ways that it can be done with culture of a sterile site in the body, but of course, since BAL is not considered sterile, since there can be colonization, positive BAL culture cannot serve as a criterion for proven fungal infection of the lung. So our impression might be that also that if we biopsy the lung and if we get into the lesion, there's almost no way that we're not going to be able to isolate the causative organism. And however, that is really not the case, as it turns out. So in a autopsy study of invasive pulmonary aspergillosis, those patients who had bronchoscopy ante-mortem, in only 1/3 of those patients was tissue invasion by Aspergillus documented. And the culture of the transbronchial biopsy was only slightly better at 44%. And it's actually been shown by researchers from MD Anderson that it turns out that it's harder to isolate mold on a tissue culture from the lung than it is on a BAL culture, and that has its own sort of mycological explanation. However, a biopsy does have the potential for unbeatable immediacy of diagnosis, as for example, if it is submitted for frozen section, as I'll show you an example in a moment. What's important to keep in mind is that, interestingly, this consensus definition of proven rather, probable and possible, was really designed as a research tool to standardize the conduct of research, but it has in some ways kind of crept its way into clinical practice, and so you will hear the terms proven and probable really used as clinical terms. And so an example of the possible immediacy of biopsy diagnosis was this case here from our institution of a 44-year-old male with new T-cell ALL on chemotherapy, persistent 0 neutrophil count, who developed fever and chest pain. Somewhat ominously, actually, beta-D-glucan and serum galactomannan were negative. Platelets were very low. So we went sort of the old-fashioned route, perhaps, and he was pumped full of platelets. Biopsies were performed of this lesion that you see here is a reverse halo, and sent it for frozen section. And voila, what we saw were non-septate hyphae with wide-angle branching that were exhibiting angioinvasion. So this was diagnostic of Mucor. Patient literally the next morning or the same night practically was in the OR, and this is the pneumonectomy specimen you see here, characterized by sort of these necrotic lesions, infarcts. So, however, things don't always go smoothly in these situations. We also had a case of a 64-year-old woman, frail patient with prior colon cancer, current AML, who had become hypoxemic. Platelet count was actually in very reasonable range. However, we knew that this patient had received at one point sorafenib, which is a molecular chemotherapeutic agent that is associated with qualitative platelet dysfunction. We thoroughly checked the chart to make sure that there had not been any receipt of sorafenib recently. This was the imaging, non-specific chest X-ray. As you see, also non-specific changes on CT. And so the decision was made to proceed with transbronchial biopsy of the left upper lobe. After the first biopsy, there was profuse monumental post-biopsy bleeding. The reason why this patient developed complete whiteout of the left hemithorax was that it just completely filled with blood. There was no stopping this bleeding. Needless to say, the patient did not do well after this catastrophic complication. And so biopsy is a common procedure, classical procedure, but not without complications. Some might say it's perhaps the riskiest diagnostic procedure that we do in traditional bronchoscopy. Moderate to severe bleeding ranges anywhere from about 1 to 3%. Pneumothorax, perhaps 1 to 4%, in some series higher than that. Perhaps if you involve trainees, it rises beyond 4%. And so, fine, if biopsy is not something we want to take the risk on, we have routine BAL analysis available. The best that BAL analysis can do for us is to establish so-called probable invasive fungal infection of the lung. What probable means is that you have a compatible host, you have compatible imaging, and you have some microbiological or biomarker evidence of infection, but it does not need to be a sterile specimen, and certainly there is no need to demonstrate the organism in culture. So BAL in tissue culture. So BAL culture is sufficient for this as our BAL biomarkers. The problem is that routine BAL is no great shakes when it comes to identifying fungal infection of the lung. So, for example, routine BAL culture, fungal culture, in autopsy studies of invasive pulmonary aspergillosis in the ICU only was in the 45 to 58% range, or has been shown to be in that range. In traditional immunocompromised hosts, it's right in that same range at 56%. And if you were to take patients who are on mold active antifungal therapy, like patients with heme malignancy or stem cell transplant, these numbers of culture yield are likely to be even lower. BAL cytology in Aspergillus, no great shakes either, a somewhat familiar number, 42% yield. And if you're dealing with Mucor, then best of luck in making that diagnosis with BAL culture. And there's now a classic series from MD Anderson of autopsy-proven cases in which the yield of BAL culture was only a meager 25%. So if routine diagnostics are that poor, this is where the present tense may be molecular BAL diagnostics coming to the rescue. And so what is available to us for fungal infection is BAL galactomannan testing, BAL aspergillus PCR, BAL mucorales PCR. These are ones we'll cover in subsequent slides. To reiterate here, we're going for so-called probable invasive pulmonary fungal infection. And it shouldn't really be that foreign to us now in the post-COVID era that we make the diagnosis of pneumonia in a somewhat indirect fashion. Because if you think about how we've been diagnosing COVID pneumonia for the last 3 years, it's very similar to the paradigm for probable invasive fungal infection of the lung. We take a compatible clinical picture, we combine it with a compatible radiological picture, and then we go looking for the antigen or for PCR in the nose of all things, not in the lung. And we certainly don't do BALs. And definitely do not do biopsies typically. And with this combination, never having entered the lung, in fact, we have been making the diagnosis of COVID pneumonia now routinely for the last 3 years or so. The other remaining molecular diagnostic test in BAL that I will discuss is PCP PCR. So a classical example of BAL galactomannan, the role of BAL galactomannan, 29-year-old male with ALL, no neutrophils, but with fever and no platelets. This bronchoscopy was limited to BAL of this lesion with a halo, consolidation with surrounding ground glass, so not a reverse halo, but a regular halo. And BAL galactomannan was sky high, and so probable invasive pulmonary aspergillosis could be easily diagnosed. So galactomannan, here's a diagram, is a polysaccharide component of the aspergillus cell wall. In the familiar assay that many institutions are using, it is detected by ELISA in serum or BAL. It's important to keep in mind it's quite specific for aspergillus, but not entirely 100% unique to aspergillus. So there can be cross-reactivity of galactomannan with other fungi. What is its performance? This is a study of 250 or so mixed immunocompromised hosts with solid organ transplants more frequent than heme malignancy in this sample. These are typical robust performance characteristics of BAL galactomannan. Maybe a little bit inflated in this study because case ascertainment of cases of invasive pulmonary aspergillosis were somewhat shaky here, perhaps. They accepted probable, they accepted even possible cases. Nonetheless, you see the pretty typical robust sensitivity in the 90s and specificity in the high 80s. What I like about this particular study is that they graphed the pre-test probability of invasive pulmonary aspergillosis versus the post-test probability, depending on for various cutoff values for BAL galactomannan. And the most typical cutoff is 0.5 optical density index. And so I have actually added bars here for a hypothetical case of 50-50 pretest probability of invasive pulmonary aspergillosis, meaning you're on the fence about that diagnosis in this patient. And so if you drop a vertical line from the 50% pretest probability and use the blue curve here for the cutoff of 0.5, then a positive result will raise your pretest probability of 50% to the post-test probability of nearly 90%. So clearly, this test will move the needle if it comes back positive. And on the right-hand side is the negative likelihood ratio graph. And I did not draw similar lines in the graph on the right, but you can see that if you're starting out with a 50-50 pretest probability and you end up with a negative BL-galactomannan value, then that really takes the post-test probability of the patient having invasive pulmonary aspergillosis very, very close to zero. The situation isn't perhaps always as rosy as in that study on the prior slide. This is a more recent study of hematology cases. 2/3 of them were stem cell transplants, 20% were neutropenics. What's noteworthy, and maybe the caveat here, is that, as would be expected in this population, nearly 3/4 of these patients were on antifungal therapy at the time of bronchoscopy. But galactomannan, BL-galactomannan cutoff was the standard one. And what you see is somewhat dampened sensitivity here and somewhat dampened specificity. So not quite the same performance characteristics as seen elsewhere. And this may be, as we will see, certainly a function of the antifungal treatment present at time of bronchoscopy. So the most recent systematic review and meta-analysis of BL-galactomannan performance characteristics actually comes from our 2019 ATS guideline document. And you see still fairly robust numbers when the studies were meta-analyzed with a sensitivity of 84% and specificity of 88%. And so when faced with the question about whether to recommend galactomannan BAL testing, what we issued as the recommendation is excerpted here, and it states that in patients suspected of having invasive fungal diseases with strong risk factors for invasive pulmonary aspergillosis, we recommend BAL testing with galactomannan. And this received a strong recommendation and was deemed to be supported by high quality evidence by our guideline group. So now turning to BAL aspergillus PCR. Its role, I would say, is to complement BAL-galactomannan and cover any of its sensitivity and specificity gaps. One possible gap we already saw, that is the administration of antifungals at time of bronchoscopy. Another, of course, is cross-reactivity. Remember that galactomannan is not unique to aspergillus; it's not 100% unique, whereas aspergillus PCR, of course, will be positive only in the presence of aspergillus organisms. One caveat to remember about this PCR, as with all PCRs, there's the possibility, of course, of detecting colonization. That's not unique to aspergillus PCR by any means. So there is a systematic review that we did not update during the guideline process. It dates back to 2012 and largely formed the basis of our guideline review of BAL aspergillus PCR. You see that in all studies, the sensitivity is quite robust, 90%, but actually perfect, if you can believe it, in studies that had the most robust case ascertainment, that were very guideline or adherent when it came to defining cases of invasive pulmonary aspergillosis. And specificity was likewise shown to be very high here in the 90%. However, again, a little bit of a wrinkle in those 3 studies that enrolled patients who were receiving antifungal therapy at time of bronchoscopy. In these 3 studies, more than half of the patients were being treated for mold infection at time of bronchoscopy. The sensitivity did drop to 58%. However, more encouragingly, a study that looked specifically at what happens to the sensitivity of BAL aspergillus PCR in the setting of antifungal therapy, we see here that actually in the presence of one antifungal agent in this dedicated study of exclusively patients on antifungals, the administration of one antifungal did not significantly lower the sensitivity of aspergillus PCR. It only was significantly lowered in the presence of at least 2 antifungal agents. When we look at BAL galactomannan and BAL aspergillus PCR side by side, what we see is that they have very comparable in this systematic review. They have very comparable sensitivities and very comparable specificities. However, what's noteworthy is that those studies in which defined a positive bronchoscopy for invasive pulmonary aspergillosis as positivity of either galactomannan or PCR, in the setting of that definition of positivity, the sensitivity was actually significantly greater than if positivity was defined as just positivity of galactomannan. And this increase in sensitivity when positivity was defined as galactomannan or PCR was achieved without any significant sacrifice in specificity. I thought this was interesting to throw into the mix. One of the problems with the molecular diagnostics in BAL in these days is the lack of any point of care option for testing, and thus potential problems with turnaround times. So what's interesting is that there is a test, a point of care test does exist. It's the so-called lateral flow device for Aspergillus. In the past, I would have said that it's very reminiscent of a pregnancy test, but in the modern era, I would rather say that it's very reminiscent of our now ubiquitous home COVID antigen test. So we're all, I think, intimately familiar with the one-line, two-line, appearance or results. And so this is exactly the same principle. There is a lateral flow device, and it seems fantastical to be able to perhaps collect a BAL specimen in the ICU at the bedside, and then, in a matter of minutes, inject it onto the little plate like we do for COVID and get a result. That's the good news. The bad news is this is not yet available in the United States. And the antibody that's employed for this testing can be, again, to galactomannan or can be to a different glycoprotein. And studies show sensitivity to be a little bit less than specificity of this test, and both have been reported to be in the 80% range. So shifting gears to a very vexing invasive fungal infection of the lung, mucor, and there is BAL PCR for mucorales. We employed it in this particular example here of a patient in our institution with AML and neutropenia, in consolidation with surrounding ground glass, suspicious for a fungal infection. This was a ill individual, not a candidate for surgery, really. So BAL PCR testing was limited to mucor BAL PCR. This result was positive, and certainly you could see that without surgery, as usually happens, despite aggressive antifungal therapy, the patient was practically, eventually, the right lung was engulfed by, mucor overspreading that right hemithorax. The sensitivity and specificity, much less studied, of course, than in BAL Aspergillus PCR, but sensitivity and specificity of 100 and 97% respectively in a small study. If this PCR is not performed in-house, which is typically the case, that it is not performed in-house, of course, turnaround times will be an issue for patients who are potential surgical candidates. So now moving on to pneumocystis and BAL PCP PCR. So this is actually a classic study now from the late 80s, performed by my ATS colleague and collaborator, Andy Limper, at the Mayo Clinic. I think at that time he was a resident or a fellow. And this is that sort of seminal study that demonstrated that patients with pneumocystis who are not AIDS patients have a much lower organism burden in pneumocystis infection than our AIDS patients. And so the reason why this observation was so revolutionary or so important, perhaps, is that it correlates with the fact that non-AIDS PCP patients exhibit much lower sensitivity of standard BAL techniques, such as silver staining and DFA, relative to their HIV counterparts. So normally in the AIDS patient, BAL testing with silver staining and DFA is very sensitive. However, that is definitely not the case in patients who are non-AIDS with PCP. Biopsy should have a high yield, of course, in both types of PCP patients. But as I've alluded to a few times in the course of this discussion, we're trying to relegate biopsy to the past in these cases, and it is not always feasible. Why might it not be feasible? Here's an example from our institution: 79-year-old male, prior cardiac transplant, who's now hypoxemic, but the patient is taking clopidogrel. So here's the current chest X-ray, limited to X-rays here. Here's the baseline X-ray. Certainly not a bad case to be made here for pneumocystis. Why don't we just biopsy and find out? However, this patient is on clopidogrel, which all but precludes the performance of transbronchial biopsy. And so in a case like this, PCP PCR could be really revolutionary. And its value was shown nicely in one prospective study in which over half of HIV negative patients were diagnosed with pneumocystis only thanks to PCR. However, in that same study, if you looked at the HIV positive patients, only 17% of them were diagnosed solely on the basis of PCR, with PCR being the only positive test. Negative predictive value of PCP PCR across the board is uniformly high, close to 100%. There are questions that remain about its positive predictive value because there is such a thing as pneumocystis colonization, as it turns out. And so the differentiation of infection versus colonization of pneumocystis is really often not a trivial matter. So there are some techniques proposed to try to improve the positive predictive value of BAL PCP PCR. Examples of such techniques might be concurrent testing of serum for beta D glucan, or by quantitating the PCR, or perhaps by doing both. And so once again, as we near the end, I turn to the document that I mentioned at the beginning, published in the White Journal just literally days or a week ago by some of my colleagues at the ATS, talking about pneumonia in the immunocompromised host. And in that document is a table that they put together listing the BAL testing that is possible for the evaluation of the immunocompromised host. And so if you refer to that document at your leisure, you could sort of run through this list of possible BAL tests that are now available in the modern era. It's a pretty comprehensive list, I would say. I was only able to add a couple of items that I thought were relevant. One missing item here I thought was nocardia PCR, a legitimate opportunistic infection concern in patients with impaired cell-mediated immunity, as well as PCR testing for HHV-8, the viral etiologic agent of Kaposi sarcoma. And so BAL PCR testing for HHV-8 is a very sensitive and specific test for pulmonary KS, which of course we don't encounter nearly as often, I think, now in the modern era as we did decades ago. So we've talked about really the scope of available molecular diagnostic testing of BAL, the sort of the traditional, what's now considered, I think, arguably the standard, the present tense, I should say. However, during the pandemic, because of the pandemic in part, I think our community missed out on the buzz about what might be the future of molecular BAL testing for infection. And that is something that is called metagenomic testing. And I will use this diagram to quickly illustrate the difference. So here on the left side is our standard PCR techniques, and I will draw the analogy between this and criminology in order to try to explain the difference between targeted sequencing and what's called metagenomic sequencing, or the so-called shotgun approach. So on the left, in our more traditional targeted approach, the analogy would be if we were investigating a crime scene, what we would do is we would normally go about collecting information from different sources about who could have committed the crime, who could have been the culprit, interview witnesses, do all kinds of investigation. And then once we had narrowed down the possibilities to, let's say, a few individuals, we would go back to the crime scene and try to dust the crime scene to see if we can find the fingerprints of those particular suspects that we had identified in the course of our investigation. And so this is analogous to what we do currently, which is we send PCRs for targeted PCR aimed at specific suspects, and then we look for those suspects by amplifying, let's say, the 16S rRNA of a particular bacterial suspect, or the 18S rRNA of a particular fungal suspect, and then see if we can identify that suspect as having been at the crime scene. However, the shotgun approach, possibly the future of such diagnostics, takes arguably the opposite approach, in that the investigator goes to the crime scene, starts actually by dusting for fingerprints at the crime scene, obtains the fingerprints of anybody and everybody who actually had left fingerprints at the crime scene, and then uses those fingerprints, references those fingerprints against a library of an infinitely long library of potential suspects, and tries to identify the guilty party from that long list of suspects whose description matches, or whose fingerprints match what was found at the crime scene. And then those people or those suspects who are identified based on dusting the crime scene fingerprints are then investigated to see how likely they are to actually be the criminal, or the person who, or the murderer, if you will. And so these, as you can see, work in reverse order. And so in metagenomic sequencing, which requires next generation sequencing technology, a BAL sample, or sample of many other types, is subjected to this really high throughput, tremendously broad amplification, and then whatever putative organism may be identified is compared to a library and reported in a list of possible suspects that then the clinician needs to sort through and identify whether which is plausible and which is implausible. And so this shift may be the future of BAL infection diagnostics, and in some respects may already be the present, because here's a PubMed snapshot of search results if one were to enter metagenomic next generation sequencing and BAL. And as you can see, prior to the pandemic almost, there were practically no hits with these keywords. And since the pandemic, there really has been an explosion, perhaps in some ways overshadowed by all things COVID. And so if one goes to the literature now, there is just a plethora of studies looking at this concept. And this is perhaps the seminal work out of UCSF. But since then, there's been really, again, as I said, an explosion of articles coming out daily almost, looking at the application of metagenomic NGS for the diagnosis of opportunistic infections, specifically fungal infections in BAL specimens. I'd like to conclude before getting to really my conclusions with just a recent case from our institution of immunocompromised patient. This happens to be a patient with breast cancer on sort of molecular chemotherapy and with ribociclib, easy for me to say, which does result in a certain degree of immunosuppression. Again, patient originally from Haiti. This is a nice snapshot of her chest CT through the upper lobes, where on the right side you see a diffuse disease with mixed consolidation ground glass. On the right and on the left, you see a cavitary lesion, very suggestive of possible opportunistic infection. This is a woman from an area that's rife with tuberculosis. And so the question is, what do you do in this case? Perhaps the right side, is more justifiable for a biopsy. However, I think there's a high likelihood of non-specific findings coming out of that. Whereas the left side, if our suspicion is for opportunistic infection, well, hopefully I've done something to convince you that this is, in the modern era, a really good target for bronchoscopy limited to contemporary BAL testing. So in conclusion, right at the hour, I would like to just leave you with these points that even basic BAL fluid testing for infection has actually been shown to outperform transbronchial biopsy in the diagnostic category of infection in the immunocompromised host. And the addition of contemporary molecular BAL fluid testing for infection, PCRs, galactomannan, would be expected to further widen the gap between BAL and biopsy. The field of bronchoscopy for opportunistic infections continues to move in the direction of lower risk. By that, I have implied throughout no transbronchial biopsy, yet at the same time, higher diagnostic yield from BAL alone. Transbronchial biopsy can be justified in the immunocompromised host almost exclusively, I would argue, for non-infectious considerations. However, availability, turnaround times, and the possibility of colonization remain some of the challenges of molecular BAL diagnostics. So with that, I'd like to conclude and thank you, and leave you with my email address and also a picture of the beautiful and picturesque Hudson River Valley where I'm currently located. This is a little out of season. This is fall foliage. We're not in that season right now, but nonetheless, I couldn't resist the temptation. So with that, I'd like to thank you for your attention, and I turn it over back to Dr. Kishishin.
Thank you, Dr. Epelbaum. Thank you for great talk. And this is very, very important and kind of real life, like a topic that we encounter every day in our practice. Before we move to our Q&A section, I just want to remind our listeners to type their questions in the chat box so that we can answer them. And I just want to go ahead and ask a couple of questions, Dr. Epelbaum, if you don't mind. So, because I was trained in the same hospital that you're working now, I just have I know how it works. It's a big center, transplant center. You have a special department for like a liquid malignancy and hematologic malignancies. And my question is like this: we know that those patients, they are very sick. They are high. They have a high morbidity and mortality, and sometimes there's a lot of peer pressure from oncologists, from transplant ID. And I just want to know your opinion about having a multidisciplinary team approach in this type of patients when they have a severe coagulopathy, low platelets, INR is kind of coagulation panel is like not normal, and they're a high risk. And what do you think? Do you think that we need to have a multidisciplinary team approach before deciding doing any invasive testing, like lung biopsy, bronchoscopy, any type of invasive testing? Thank you.
Yeah, I think that's a great question. And as much as multidisciplinary discussions formally exist for certain other areas in our field, like we know about MDD for interstitial lung disease, for instance, we know about PERT. For, let's say, pulmonary embolism, just to name a few. I'm not aware of anything that truly exists formally for the approach to bronchoscopic diagnosis of the immunocompromised host with suspected infection, but I think I'm 100% on board that that is the optimal way to plan the procedure, and personally, that's unofficially the approach that I almost invariably take when confronted with these cases, because I think we as the bronchoscopists understand our side of the story, based on the data that I've shown and experience and other factors. But there's, I think, extremely valuable input to be gained from, for example, our infectious disease colleagues, transplant infectious disease or not. For example, it's, I think, very useful to get a good sense from them as to what they think the patient's immunosuppression leaves them most vulnerable to. What are the top considerations? How high is infection versus non-infectious processes on the differential? Among the infections, what are the top concerns? Because I think their input on that can definitely help guide the procedure and avoid perhaps doing too much, or in some cases doing too little. Obviously, not to be overlooked are the oncologists or the transplant docs for the patient, who have a certain insight, perhaps into what may have been going on with the patient, how urgent is the diagnosis, what are the subsequent possible planned interventions or treatments that the patient would be eligible to receive. And so I agree with you. I think there's no MDD that I'm aware of in existence officially for procedural decision making for this very challenging population. But if it doesn't exist formally, I think it should be practiced informally to optimize the safety and actually the yield.
Thank you. I agree, because sometimes even oncologists, and they just continue to treat these infections, assuming that they are infectious or fungal infections, and I don't know even if your bronchoscopy and biopsy negative, that stops them to continue the medication. That's another question. I think having multidisciplinary team, kind of having the oncologist and the transplant ID or ID and the pulmonologist, kind of gonna set the rule that yes, we can take a chance. We're doing this, and kind of even debating BAL versus BAL plus lung biopsy, because that's the lung biopsy, which is kind of you get more complication with these patients with low platelets and the coagulopathy. So I agree with that. Thank you, Dr. Epelbaum. Question about how you change your decision making about doing BAL, and especially BAL with the lung biopsy, if you have a serological blood testing which is not supporting, let's say, fungal infection. Let's say if your fungital is negative in the blood, but you still have a immunocompromised patient, and you still have a radiologic, like a picture, which could be like let's say fungal infection, and how that change your differential, and is it really making you think that a patient you can do more harm if you do bronchoscopy with a biopsy?
Right. So I think this again brings us back to arguably the multidisciplinary discussion and enlisting the oncologist, or let's say the transplant docs, into the conversation, because I think as much as our community needs to think hard about the meaning of let's say negative fungal markers, our colleagues may also not have a full appreciation of what negative fungal markers in the blood rule out and what they don't rule out. And so I think it's part of this multidisciplinary discussion, so-called, is really a conversation about what the negative fungal markers mean. So, for example, what is missed with beta-D-glucan testing in the blood? So, for example, Mucor, Blasto, Crypto. Certain what are the holes in the serological testing? Similarly, in what kind of patients is there a decreased sensitivity of blood galactomannan testing, such as patients who are less immunosuppressed? The less immunosuppression, really, the lower the sensitivity of blood galactomannan. So I think holes in serological testing need to be considered in refining your differential diagnosis, and also in maybe correcting some of the possibly false impressions that our colleagues in oncology or transplant could be under. And I think incorporating the results of serological testing could also have an impact on the type of bronchoscopy that we end up doing subsequently. Because, for example, a completely negative serological panel of beta-D-glucan and galactomannan in a patient with still suspected fungal infection, like the case I showed relatively early in my presentation, really increases suspicion for Mucor. And so, a fungal-looking lesion in a neutropenic patient with negative serological testing for galactomannan and beta-D-glucan could point you squarely, or should point you squarely, in the direction of Mucor, and that may change the type of bronchoscopic procedure that you end up performing.
Okay, thank you, Dr. Epelbaum. There's a question from audience. It's a long question, but I'm gonna kind of read through it. And so the question is about the immunocompromised host, and to say that whenever you are kind of the patient is immunocompromised, but you're thinking infections versus inflammatory like a process, what's your approach? Is it reasonable to first perform BAL to rule out infection, and then if there is no infection, let's say after BAL and all this molecular testing, then you can kind of take the patient for a second bronchoscopy with lung biopsy to rule out the non-infectious causes. And just listener is wondering, or that doesn't work. You want to do one procedure and get it done. So what's your take on this?
Right. So that's a I guess a pragmatic question. Where nobody, I think, no patient, no bronchoscopist typically likes to go in for a second procedure. I think the advantage of judicious use of BAL for opportunistic infection is that a exclusion of infection with that procedure could leave you with a relatively limited array of non-infectious possibilities in that patient, and that's, I guess, where the pulmonologist's skill comes in trying to prioritize what could be the non-infectious alternatives to infection in that patient. And perhaps that that properly performed, very sensitive BAL with all the requisite testing for infection, the negative results of that testing could arguably obviate the need for a repeat bronchoscopy, leaving you with just a decision as to whether you think the non-infectious substrate is steroid sensitive or not steroid sensitive, and then I think make the very common in pulmonary medicine decision as to whether to administer steroids without a definitive tissue diagnosis or not to administer. So I think a negative but comprehensive and properly targeted bronchoscopy with BAL in the immunocompromised host could open the avenue then for administration of corticosteroids if the judgment call by the pulmonologist is that a steroid-sensitive substrate like organizing pneumonia is likely.
Thank you, Dr. Epelbaum. I think it also depends on is it outpatient or inpatient procedure. It's easy to do the second procedure. Someone who is outpatient, you can do the first and rule out some kind of infection or something, then go back, do more aggressive procedure. But in inpatient, it's a little bit tough. You don't want to, because you need time, and you don't want a patient to stay in the hospital for several weeks to see if this is infection kind of ruled out. Now you're trying different things or steroids to see if there's a difference. But I think thank you for answering this question, Dr. Epelbaum. And the last one that I have, you mentioned about two platforms, BioFire and Univero, yes? So,
yes.
Are you aware about the pricing? How pricey is these things? And because you're going the process of incorporating in your hospital, so how that works? And do you think it's feasible for small community hospitals, or just going to be in the big centers?
Right, that's a good question. So, if the thing is that there is a number of panels that each of these manufacturers offers. And especially in the post-COVID or COVID era, there's a good chance that one of these platforms may already be present in the institution, but it's being used to perform other panels. So most notably, in our current experience, respiratory viral panel. So if there's a respiratory viral panel that is being performed at the institution, there's a good chance that it's being performed using one of these platforms. Another thing that at least the BioFire platform offers is a so-called GI PCR multiplex for GI pathogens for stool testing. So if one or both or any of the other platforms that they might offer is available at the institution, then the basic technology is already there. And so it's a matter of acquisition of the sort of the cassette, if you will, that is then plugged in essentially to allow you to test for the lower respiratory tract bacterial and viral pathogens, and of course, as I showed, antibiotic resistance mutations. So I would, if this particular panel is not known to exist in a given institution, the first question I would ask the laboratory or investigate is whether or not the fundamental technology is there, and other panels are performed, and it's just a matter of acquiring this particular panel of interest, which is a much smaller ask than to introduce the technology from scratch. Once it's a matter of obtaining the panel, it's much smoother sailing. I mean, there are certainly obstacles that could come in the way in terms of getting it implemented, making sure it's performing accurately, standardization, reporting of results, etc. But if other panels are available, then I think the addition of that next panel is not that complicated, even in a very, slow and bureaucratic institution that Westchester Medical Center sometimes can be. So, yeah, I think it's not going to be limited to small community hospitals. Multiplex PCR testing came into its own, arguably, in COVID times, and it's not going away, and it's not, I think, the future. It's really the present at this point.
Thank you, Dr. Epelbaum. Again, thank you to participating in today's webinar. It was great, and I want to thank our listeners that join us tonight. And I hope to have you see you next time in our webinar. Thank you. Have a great evening.
Thank you, Sevek, and thanks to everybody for listening.
Thank you.